So, what's troubling you today, John?
I have this really weird-looking rash thing on my chest. It's kind of below my collarbone, and it's become really itchy over the last day. It's really bad at the moment, actually, and I can't stop scratching it. I mean, I'm trying, but it's too hard, and it looks all kind of scaly and pink. It's pretty weird. And then yesterday morning, after my shower, I noticed there's a lot more of these little spots coming up around it. There'd only been a few up until then. It's definitely getting worse, look.
Okay. Well, that looks like what we call pityriasis rosea. A fancy name for a rash, really. It's common for your age group. Have you been ill at all recently?
I had a bit of a cold for a few days last week. Just a runny nose, sneezing, that kind of thing. I'm fine now, though. About 3 weeks back, I had a really bad nosebleed, and my mum took me to emergency, and it ended up being nothing.
Having a cold right prior to an outbreak is quite common too. The rash usually clears up by itself after a couple of months and rarely reappears, but you'll need to avoid excessive sun and regularly apply generous amounts of moisturiser.
But I have a beach party this weekend at my mate's holiday house. If I can't be out in the sun, then there's no point going. I mean, it's actually his 18th, and he's my best mate. Also, this looks pretty disgusting, and there'll be lots of people there. Isn't there something I can take to help clear it up, or at least stop it from spreading more? Because if that happens, by the weekend, it could cover my whole body.
Oh, that won't happen, I can assure you. But you will have to keep your shirt on for the hottest part of the day. Do you have any allergies, John?
Yeah, I've been allergic to dust mites since I was about 13, I think, so my mum's always cleaning. My skin usually just gets really itchy, and I sneeze like mad. When I was really young, I was allergic to milk, but I'm over that now. The only other thing I have to keep away from is that stuff they put in cheap takeaway food to make it taste nicer. Oh, what's it called? MSG, that's it. That stuff gives me shocking headaches, makes me so tired that I can't do anything for about a day.
How about medical history? Have you ever had any major illnesses or operations?
I had chickenpox when I was a toddler, but I've also had to go to hospital 4 times for things. I've been a skateboarder since I was 6, so I've had a few spills. I broke my left wrist when I was about 8 years old, skating off a quarter pipe. That was a pretty bad one, but I made it over 5 of my friends who were all lined up on the ground. Then later, I'm not sure how old I was, maybe 11, I had one of those really small breaks, like a hairline fracture in my elbow. I also broke 2 of my fingers on my right hand. I had to have them strapped up. That was a pain. And then my last one was last year, and was probably the worst because it was so painful. It made the other ones seem like a joke. I had to go into emergency because of some pretty serious grazing along my leg. I came off my board going down a hill on the side of this really rough road. It had dirt all in the wound. They just washed it out and put bandages all up my leg, but I was in agony.
Well, hopefully that'll be the last of your injuries.
So, Declan, you've been referred to me because you've been experiencing digestive problems. Before I examine you, perhaps you could tell me in your own words the history of the condition.
Well, it all started about 3 years ago. I suddenly found I was having issues keeping food and drink down. So I went to the doctor and he said, well, what you're describing, it sounds like acid reflux. Well, I'd heard of that and I didn't think that's what it was. Anyway, he prescribed a course of H2 receptor blockers and said, just try, and if this doesn't work, then we'll schedule some tests.
And?
Well, I was right to be sceptical because they didn't work. So I ended up going for an endoscopy, and my GP was surprised. He said, you were right, there is something else going on. They'd taken a biopsy of my stomach, and there was a problem with the bacteria there. So he put me on a triple antibiotic, and I was on that for 21 days.
And did that help?
I did feel a bit better, but if I ate certain foods, they'd still get stuck in my throat. like when I was eating bread, that sort of thing. Then fast forward to this time last year, and I had the same episode again. I just couldn't keep the food down. Only this time, it wasn't only that. I also had a feeling like my stomach was burning. It was horrible, like my insides were on fire or something. I thought it would pass like the other symptoms did, but actually it just got more and more intense, so I called the hospital and the paramedics came out to get me.
So what happened there?
Well, they did some tests. They took a stool sample, and they told me they were going to analyse that to see what was going on down there. Anyway, eventually I was told I'd been diagnosed with colitis, and again was prescribed antibiotics. So I took them, but within an hour or two of taking those pills, I was throwing up again.
Right.
So I ended up back in hospital because I couldn't keep anything down, and I was really suffering from fatigue. I was having trouble even standing at this point, and basically everything hurt. So they admitted me and put me on an IV for fluids because I was dehydrated and malnourished.
And they did more tests?
Yes, this time they gave me a barium swallow test and took an X-ray of my chest area. What that showed was that I had a disorder in my esophagus. Basically, the endings of the nerve cells are supposed to move the food down my esophagus to my stomach, and so signal to my LES muscle to relax and allow the food into my stomach. But because these nerves aren't working, there's no signal and the muscle doesn't open.
So they diagnosed achalasia?
That's right. They told me I'd have to manage the condition somehow. I mean, that's okay because it's not all the time. I have these episodes where I can't keep anything down. Then for a while I'm okay as long as I'm careful. I keep to a mostly liquid diet or go for food that's easy to break down. I watch the texture of the solid stuff I eat and keep to small portions. Another thing that's helped is having carbonated drinks at mealtimes because burping helps to get the LES working.
That's right. OK, well, I think I've got the picture now. Next, I'd like to ask what you're hoping I can do for you.
Well, I was looking on the internet and I saw that there's a new form of surgery that's been developed that might make a difference to me. My GP said you'd be able to tell me about that.
OK, well, let's begin by analysing.
John, there was a written complaint filed from Mr. Boeing in room 6. He says that he requested a private room last night, which you promised he would get. Then you ignored his attempts to speak with you, even when he was in considerable pain. What happened?
He asked to be moved because he was uncomfortable and in a lot of pain. Unfortunately, Mrs. Stewart took a turn for the worse and needed closer monitoring. I needed to prioritise the ward accordingly. He received all pain medication at the correct time.
I see.
Normally, I'd have discussed it with him, but time just didn't allow for it. I had to be where I was needed most, and that was taking care of Mrs. Stewart.
Your job is to prioritise, and you did just that. I'll go in and talk to him and see if he still wants to pursue it, because it's quite a serious allegation.
Okay.
Well, you've got what's known as a bunion.
It's just so ugly. I've even stopped wearing open-toed shoes. How did this happen? I mean, I'm far too young to have this.
That's actually a common misconception. The condition can be inherited or even associated with diseases of the joints like osteoarthritis. But the most common cause is poorly fitting footwear, particularly shoes with narrow toe boxes.
Most of mine do have rather narrow ends. But surely that can't change the shape of your foot. I mean, my big toe's pointing in the wrong direction.
What actually happens is the metatarsal, which is the long bone in the middle of your foot, deviates towards the other foot, while the hallux, otherwise known as the big toe, pushes towards the other toes, so we get a very prominent joint protruding outwards, such as you have here.
I see.
OK, so when you're dealing with asthma patients, it's quite likely that they'll ask you about exercise, and you're going to have to make a quick assessment of what it's appropriate to say. Basically, by giving their lungs a regular workout, they'll cut the risk of asthma symptoms. But if they've never had a regular exercise routine before, the first thing they need to do is go to the GP for a checkup and make sure their asthma action plan's up to date. Most patients can fit some regular exercise into their week, and you should stress that little changes will make a huge difference. So simply just walking the kids to school or taking a walk in the lunch break instead of sitting down could make an enormous difference. Also, if they can find somebody they know who's willing to go with them along that journey, that'll help massively as well. But remind them that whatever they do, they'll always need to have their blue reliever inhaler with them.
OK, we need to do our debriefing. Any comments about the case, Jackie?
Well, we were late getting started due to a delay in getting the surgical consent to come in, but I've talked to the junior resident, and I think we just had a few crossed wires there, so it's sorted.
Yeah, we were busy in clinic this morning, but we were also delayed getting into this room because the case before us went over their time, which pushed us back. That's becoming a regular occurrence with that particular team. I'm going to ask our nurse manager to adjust their time slots based on the recent history of their cases.
We were also slow to get the portable films from radiology. There were several rooms requesting films, and radiology seemed short-staffed. That's unusual for them, but let's keep an eye on that, and if it happens again, raise it as a concern.
So, Mr. Clark, you'll need to keep the cast dry, which means covering it with a plastic bag when taking a shower. I'm sure you'll manage.
If the cast does get wet, I can use a hairdryer, can't I?
Yes, put it on a cool setting, though. One other thing, it's easy to forget to exercise the shoulder and the elbow. Don't sit all day like a statue.
Right. And it's not normal to feel any tingling or numbness.
It's unlikely to happen, but inform us as soon as possible if it does. After a day or two, some people can start to feel the cast is too tight or too loose. Again, if that's an issue, you should let us know.
Okay, so you can adjust it?
Actually, we can replace the cast if there's any discomfort.
Ah.
Before changing the dressing, if there are any particular instructions regarding how to deal with Mrs. Harris or the ulcer, you'll be given them at the start of the shift. You won't ever have to access her records yourself and scroll through everything. There's an equipment checklist here with the type of cleaning solution and forceps you need, so you'll know that off by heart. You'll see that a face mask isn't essential, though some nurses prefer to have one. As you know very well, you should chat to Mrs. Harris very briefly about what you'll be doing, even when she gets familiar with the routine. Now, please take great care in recording the condition of the skin surrounding the wound, plus the presence of any sort of inflammation, discoloration, or odor. This assessment has got to be thorough. Then get her in a position that's comfortable for her, and you can begin.
Okay.
As a physiotherapist of 22 years, I've been asked all sorts of questions, but the one I hear most often is, can physiotherapy help my condition? Physiotherapy assesses, diagnoses, treats, and prevents a wide range of health conditions and movement disorders. It helps reduce pain and repair damage while increasing mobility and improving quality of life. In some instances, it can be an effective replacement for surgical intervention. Obviously, not all conditions can be cured by physiotherapy alone, but help it can certainly do. So today, I'd like to focus on a condition that still creates controversy when mentioned alongside physiotherapy, and that is scoliosis. Can physiotherapy make an impact on someone suffering from this condition, in particular mild to moderate scoliosis? Let's find out. Scoliosis isn't always easy to treat, but understanding this condition and its related issues will help a physiotherapist determine the best possible options. A scoliotic spine has one or more curves to either side exceeding 10 degrees. It can resemble a C or an S shape. What makes it difficult to treat is that the majority of cases have no known cause. Two specific types are easier to deal with, however: structural scoliosis, which results from the development of the musculoskeletal system, and functional scoliosis, which occurs from muscle imbalances, leg length discrepancies, and inflammation of the tissues. These both have definite causes, allowing us to create an individualized and comprehensive treatment plan. Physiotherapy is but one part of the multidisciplinary network of healthcare professions employed in the treatment of scoliosis. A confirmed diagnosis comes firstly from a thorough physical examination for any abnormalities and asymmetry. If scoliosis is suspected, then an X-ray will be taken to confirm what's known as the patient's Cobb angle, or severity of the scoliosis. From here, physiotherapists work closely with doctors, including orthopedic spine specialists, in determining the best options going forward. I believe a good, multifaceted approach to this is ideally broken down into 4 distinct phases. The first of these, in my program, is pain relief. Although not all scoliosis sufferers will experience pain or even discomfort, many do, and for these patients, the provision of pain relief assists with compliance and also with corrective or prevention exercises. Physiotherapists have a variety of techniques for achieving this, such as the releasing of tight muscles through gentle massage, acupuncture, the use of supportive postural taping, and various electrotherapy modalities such as ultrasound. Phase 2 is a particularly important step for several reasons. It's for rectifying any imbalances through stretching and strengthening exercises. This often still includes taping techniques until strength and flexibility have increased. Physiotherapy here focuses on both sides of the spine as well as adjacent areas like the hip or shoulder, depending on what's impacting spinal alignment. The aim is to restore the range of motion of the spine, muscle length and strength, as well as endurance and core stability. This stage is paramount for allowing ongoing treatment in Phase 3 to occur. This is because it's there that the patient requires the strength and flexibility gained in Phase 2 in order to resume normal activities. These include sport and recreation, which is the objective most patients have in mind during the treatment process. It's where we aim to restore full function. This is where we, as physiotherapists, need to tailor rehabilitation to the specific patient so they can safely achieve their functional goals. This, of course, includes trained athletes who place great stress upon their bodies, so caution must be taken when giving advice, and strong encouragement is needed for keeping to realistic recovery times. The final phase is undoubtedly the most important in terms of full recovery, and this is the prevention of a recurrence. This relies heavily on the partnership between physiotherapist and patient. By this, I mean we identify the optimal exercises for the patient to continue, and it's then up to them to maintain these exercises throughout the course of their life. Here too, other professions may be utilised. For example, in a case of an unequal leg length, a podiatrist could address this with a heel rise, shoe rise, or built-up foot orthotic. What patients expect to achieve and what is achieved varies greatly. However, those with mild to moderate scoliosis who have a commitment to maintaining their newfound strength and flexibility can expect a full recovery, especially if diagnosed and treated early. Physiotherapy is a vital part of this recovery and prevention and should never be underestimated. So, the next time you're asked, can physiotherapy help my condition, I'd be inclined to give a firm nod and respond by saying, with your commitment, physiotherapy is invaluable.
My guest today is Gary Prinslett, who's a speech and language therapist. First of all, Gary, I think there's a bit of uncertainty out there about what the work of an SLT actually involves. And it can vary, so tell us exactly what you do.
I'm a speech and language therapist working with adults in an acute hospital. I carry out communication and swallowing assessments, recommend safe consistencies for people with conditions like dysphagia, and I make referrals on for people who need ongoing help once they're discharged. A lot of people don't realise that we assess a range of things as well as language, but esophageal assessments actually account for the vast majority of patients on an acute caseload.
How did you get into this type of work?
My mum had a stroke when she was in her 20s, so I grew up with someone who had a communication disorder. She was really inspirational because she was working as a dentist before the stroke, but had to retrain to use her left hand when she was left with right-sided weakness. My son's learning disabled too, and our struggle to get a speech therapist was the final push I needed to look into training as one myself. It wasn't the career path I'd originally planned for myself.
So, what type of training did you have?
It's a degree-level job, so I went back to university as a mature student. I could have done a 2-year MSc because I'd already got a degree, but I chose the 3-year BSc so that I could still have a life. The 2-year Masters is very full-on. In the UK, the best way to get a job afterwards is to sign up to NHS jobs and apply for everything. It's been a lean few years for SLT jobs in the UK, but it's quite cyclical, so I expect the situation to improve. There are some private jobs going too, which can be good as long as there's mentoring in place.
Describe a typical day in your job.
I get in at 8:30 and we go through what we call the list, which is our daily caseload and when they need to be seen. As well as current patients, there are new referrals every day, so they get divvied up. Then I spend a few minutes plotting my route through the day, prioritising who I need to see and when they're going to be free to see me. Then I go onto the wards and do my assessments and reviews. I stop for the ward's protected lunchtime between 11:30 and 1, catch up with my admin, then see more patients in the afternoon. I'm still doing my dysphagia training, so I have to report back to my supervisor quite regularly.
And what skills do you need for this type of work?
I think you need to be a good communicator and listener, and being observant helps. But above all, in a hospital setting, there's no room for lone wolves. We work with other therapists like physios and occupational therapists, for example, as well as nurses and doctors, and we have to work together to find ways to fit all the pieces together so that the outcome for the patient and their family is the best possible. But you do get bad outcomes in an acute hospital because your patients are sick and sometimes they don't make it, despite the best efforts of everyone involved in their care. So you've got to be prepared to take that too.
What advice would you give someone wanting to break into this career?
If you want to pursue a career as a speech therapist, you need to get some experience under your belt. Some therapists will let prospective students shadow them for a day or two, though hospital departments generally won't allow that unless you have a firm offer of a place at university. But there are opportunities to volunteer with support groups and charities, so that's probably your best route. The local stroke support group took me in and were really welcoming. It's also a useful way to see if it's the right fit for you before you invest too much time in it.